Actually, somebody else, another doctor said it's, I think maybe you or some other urologist said it's the only book that a patient can read without falling asleep. Probably because of my subtle sense of humor. Uh, you can tell that Dr. Carey has his own great sense of humor. He is doubly equipped with not only an MD with a specialty in urology, but also a PhD from MIT in chemistry. And he can combine a lot of thoughts. You have a few patents too, right?
I do.
3 patents.
Three of them.
Terrific. His subject is broad, but can be very specific depending on your questions afterwards. We'll have a solid Q&A. The topic is dispelling prostate cancer myths, and we are glad to have Dr. Carey with us. Here you go.
Thank you, Ed. It's a privilege being here, and it's a privilege always getting a chance to talk to you. What I thought we would do, most of the time when I give a talk to men, we spend most of our time going through and doing a formal lecture as if I'm talking to the American Urologic Association. And sometimes we don't have enough time for questions, and people come in and they have. So in the background, we're going to just run a robotic prostatectomy. This is real time, essentially live. The surgery was one that was done just in the recent weeks. And what you can do is you can watch the steps unedited, you know, from start to finish while we're going over questions. And mostly, I'm going to talk to you about the most common questions and problems that men come to me with. I see men all the way from an elevated PSA to metastatic castrate-resistant prostate cancer. I see the things that we do well as physicians, and I see the things that maybe we shouldn't have done. And so essentially, as men come to me, they will often, you know, have gone down a certain pathway because they believed what, you know, something that maybe wasn't necessarily true. So one by one, we'll go over, you know, I think 17 points that I put there. But at any time, if anyone here in the room has a question, please go right ahead. And from time to time, I'll show you. This is just exposing the prostate. And just to get everyone oriented, these are the great vessels going to the leg. That's the vas deferens. And we're opening the space of Ritzius, which is where the prostate resides deep in the abdomen. So the first thing we'll talk about just briefly is the myth that the PSA is a bad test. We shouldn't do the PSA. If you're the federal government and you realize that a lot of wrong things or over-treatment comes from having the prostate-specific antigen test, then maybe you would say maybe we shouldn't do it. But why is the PSA a good test for most men? Because if you get a PSA and the PSA is 2.5 or less, and it's always less than 2.5, and your digital rectal exam is normal, the chances of you having a significant prostate cancer are essentially 0, okay? And those men just get out of the equation. If your PSA is greater than 10 and rising, those men almost always have prostate cancer of some degree or another, but too many of them have it already spread. And so, you know, we spend most of our time discussing what to do with the men with a PSA between 2.5 and 10. But the PSA is a great test as long as it's used intelligently by the men and their doctors. Why might you hear that the PSA is a bad test? Because I believe that we have an over-treatment problem for prostate cancer for men who don't need to be treated, and we have an under-treatment problem for men with high-grade significant disease where they're at risk to die and they're being given insignificant treatment. So a lot of times we're overly diagnosing and overly treating men who don't need treatment, and we are under-treating men who are at risk to die. And so from the federal government standpoint, they had a female pediatrician lead a group of, quote, experts that just said, just don't do the PSA testing. And of course, the problem with that is, men who end up with an elevated PSA, they don't know about it, and they present with metastatic disease. It's a terrible issue and problem. So when it's a, quote, bad test, how do we mean that? Well, as we're all sitting here discussing it, there may be a 90-year-old man at a center here in Sarasota with insignificant prostate cancer getting $100,000 worth of treatment that he doesn't need. And that's what the government didn't like. And of course, that's what doctors don't like. We just didn't do a good job of policing it ourselves. And I think that, as we look at the data of the prostate-specific antigen, we find that it does save lives and it does prevent morbidity and mortality, as long as we use it intelligently. Now, someone comes to me and says, my PSA is elevated. What's the next step? Well, the next step isn't to do a $5,000 MRI. The next step isn't to do a $500 biopsy. The next step is to say, okay, this is what your PSA is today. What was your PSA in the past? Do we know what your baseline is? Is this PSA, because some men show up with a PSA of 5 in my office and they're 65. Well, they had a PSA of 5 when they were 50. This is their normal baseline. These men often, they're just someone that has inflammation or other causes that don't require it. So you always look to see, is there PSA progression that's documented? Is there a ratio of the free to total? And we look at that and see, how does this affect you? Because if that free ratio is 25% or higher, those men almost never have prostate cancer. And what is your digital rectal exam? Okay? We don't like to find cancer by putting our finger in and feeling the back of the prostate, but if you have a rock-hard nodule, it doesn't matter what your PSA is, you need a biopsy and you need to be diagnosed. In terms of urinary symptoms, men who come in and say their urination is completely normal, well, they probably don't have benign causes of an elevated prostate-specific antigen. And we also care about your family history. If everyone in your family dies of cancer, then, we need to be much more concerned with you dying of prostate cancer than if everyone dies of heart disease. In terms of deciding what to do with an elevated PSA, we get to the decision that all of my men come in. Do we surveil it? Just keep following the PSA? Do we get imaging? Okay? And do we do a biopsy? And I always tell men, if the prostate was on the end of your elbow, we would just. Prostate is deep inside your body, and there are risks and benefits associated with it. Now, there has been a huge push to do magnetic resonance imaging of the prostate. Who here has had an MRI of their prostate? And it's not a fun thing to do sometimes. You have to lay still. And what we don't tell patients sometimes is that, do you know that we're going to be giving you a nephrotoxic dye that could be hurting your kidney? There's a substantial cost to it that, despite whatever insurance we may have, there seems to be a never-ending, chance that you're going to end up paying for more and more of it yourself. And at the same time, does it really change what we do? That's what I always tell men. Are we going to believe a negative MRI, or are we going to believe a positive MRI? I can't begin the number of men that have low-grade, insignificant prostate cancer who keep getting MRIs all the time, but it's not going to change whether we treat them or not. And so I have spent a good bit of my life doing high technology. I have built magnetic resonance imaging machines start to finish, and I am really reluctant to use it, particularly if a man comes to me with an elevated PSA progression, abnormal digital rectal exam, relatively small prostate, where I already know that in that situation, the chances of them having a positive biopsy are about 80 to 90%, you know, why would we drop $5,000, for someone who's not really going to help them, as opposed to people with large prostates who may have problems with it? It has a role, but before we drop $5,000 for something that could hurt somebody, that's what we have to think about it. How many here have had a prostate biopsy at some point in their life? We've got veterans here. It's like Veterans Day for prostate cancer. So everyone sort of remembers it. And the thing about it is, what do you learn from a prostate biopsy? We always worry about the risk and benefits. And by the way, as we look here, we've now exposed the prostate. And so what I always tell people, the first step of a prostatectomy is to make a fat man skinny and to just find the prostate. And right here, this is the bladder, this is the prostate, right here, this is the dorsal vein, and we're getting ready to tie the dorsal vein at that step. But now, people always talk about how complex it is to do a prostatectomy, and it is. I've spent a vast majority of my adult life in engineering and science and in medicine and surgery, doing a little bit of both. But, my job is to make this look easy, right? You don't see a field full of blood. You don't see a thing. This is going in, and you're trying to find out, how to do this. And you'll notice my father and grandfather and great-grandfather down to about 17, 15 were sailing ship captains. And my first job as a little boy in the rural Bahamas was doing all the dirty jobs on a sailboat. And so if anyone ever offers me the chance to go on a sailboat, there's like something visceral inside me that makes me worry that I'm going to be fiberglassing something before the day is ended. But roughly, if you'll see how I tie these knots, but basically that was one of my contributions to robotic surgery 15 or plus years ago, how to tie knots inside coffee cups. So everyone just looks how to tie the knot and then cinch it down. So what do you learn from a prostate biopsy? I routinely do these, and people walk out with the anxiety of what's going to happen. Well, first and foremost, you're going to learn yes or no, is there cancer? Where is it located? How much of it is there? And most importantly, how aggressive it is. Okay? That's the Gleason score. But more importantly, you're going to put yourself into one of three categories, all of which are good, right? One, you have no cancer, okay? And if a biopsy is done thoroughly and it's done properly by a skilled surgeon who knows how to look at a prostate under any type of imaging, if you have no cancer, that means you have no significant cancer. We're not worried about missing a microfocus that we're not going to treat, but if you get a biopsy back and there's no cancer, that's what the answer is. That's good. Number two, you could be determined that you have cancer, but it's low grade, low risk, okay? Low grade, low risk, which means you're a great candidate for active surveillance and do not need to treat you. You can opt to be treated, okay? But most of the time for these men, if they're counseled properly, you just leave my office with a plan to go on active surveillance. And the third thing it could be, right, is aggressive, high-grade, high-risk disease where you need to be treated. Now, on the surface, that sounds bad, but what's worse than being told that you have aggressive, high-grade, high-risk prostate cancer? It's having it and not knowing that you have it, because that's how the 32,000 people die of prostate cancer every year. That's the mechanism of death. Having the prostate cancer present inside you, unknown, until it spreads. How does prostate cancer spread? Almost universally through the blood. Blood flows into the prostate, blood flows out of the prostate, cancer cells circulate, and eventually some of them stick. It does go through the lymph nodes, it does go direct extension, but usually it's the hemogenous spread that ends up being the thing that causes death. Now, when you get this biopsy, right, you're going to have to make a decision as to whether or not you fit an active surveillance. And most people, when I tell them they're a candidate for active surveillance, they're scared to do it until they understand what that means. It doesn't mean that we'll never treat you. It simply means, by the way, This is a stitch that I always do. And if you notice, it's like the equivalent of a sling. This is how men can become continent, because you are taking the urethra and you're putting it up to the pubic arch, much like when women come in and they have a female sling because they're leaking. For every man who has a prostatectomy with me, I do the same thing. I don't want to say 6 months after a prostatectomy, I wish I would have done this or I wish I would have done that. This is what we do, and you can tell this is, yes, it takes a couple of minutes, but one of the lessons here is by the time you and I have a conversation on prostate cancer, you can have a prostatectomy, right? So just step by step, this is what we're doing. In terms of the aggressiveness of the prostate cancer, how do we know how aggressive it is? When I say high grade, high risk, does anybody remember being diagnosed where you told what your risk group was? What's that? Right, but it didn't really tell you 9 versus or. And so when you get a diagnosis of prostate cancer, what is your risk? How do we determine that? You know, you're given a Gleason score, okay? And I take it that yours was a Gleason score of 9. Does anybody here know how pathologists determine a Gleason score and how technologically it is? I know you know everything, but go ahead. Absolutely. It's not a complex genetic test of any sort. It is simply where the pathologist looks at the hematoxylin eosin stain slides, the classic slides where you take tissue, put it on, and then the opinion of the pathologist, this pattern is 1, 2, 3, 4, or 5. Patterns 1 and 2 I never treat, I never operate on, because no one ever dies from it. Show me the dead bodies, the crying widows, and I will treat it with more reverence. But patterns 1 and 2, we don't need to be treated. Pattern 3 gets to be more aggressive. We can see that in our metastatic patients. Pattern 4 is worse, and pattern 5 is the worst of the worst. And those are the Gleason patterns, which is not to be confused with the Gleason score. The Gleason score comes about where some men will have only pattern 3. Well, their 3 plus 3 equals 6. But some men might have a mixture of pattern 4 and pattern 5, at which point their 4 plus 5 equal 9. And depending on what they have more of, they might be a pattern 5 predominant versus pattern 4. And so ultimately what we like to do with our prostate cancer patients is give them that Gleason score. Now, there are lots of competitors right now to the Gleason score, and that's where the myths come in. If you ask anyone to say, do you want genetic testing of your prostate cancer, everyone raises their hand and says, yes, please test my genetics. Okay? Well, what does that mean? And again, you can't kid a kidder, okay? I've been around in prostate cancer for a long time. And yes, I want to give my patients as good of a pre-treatment staging and grading as possible. And so we know that some men are genetically more likely to have metastatic disease and to die of their cancer. And how do we determine this, right? So we start looking at what genes are present. And so there's something called a Prolaris test. Okay? And that looks at cell cycle progression genes. There is something called the Decipher Grid. It's a brilliant concept where they look at like 19 or 20 different specific genes for prostate cancer. And in theory, you could look at thousands of these. And then we have, other types of Oncotype DX tests that we can look at tissue. But, I'm someone that looks at red flags, all right? I want to see a genetics test where when I pay my $4,000, and yes, they will come back and take a bite out of that, even though they say, oh, don't worry, Dr. Carey, Medicare will cover it. Sure, then Medicare does cover some of it, and some of it gets back to you. What are you getting for your money? Is it going to help you make a decision. Is it better than the Gleason score? And so what's the first red flag about all the genetics tests we have? You never get the direct result of the genetics test. They always do the genetics testing, right? And then they put it into a proprietary algorithm, including your PSA, your Gleason score, your percentage of the biopsy cores, et cetera. And you know what I've found, unfortunately, is that every time someone sends out for their Gleason, sends out for one of these genetics tests, it's remarkable how their risk comes back almost exactly what their PSA, Gleason score, and percentages would have come back. And so I want to believe in the technology. Intellectually, I know that cell cycle progression genes are important. Intellectually, I know that people who have neuroendocrine derivation is important. But so far, they haven't shown me how I can counsel my patients any better. For example, if someone has Gleason 6 cancer in small amounts, these genetics tests aren't going to make me tell my patient they shouldn't go on active surveillance. And if they have high volume Gleason 9 cancer and it comes back low risk, I'm not going to tell the patient to go to follow the genetics test, because we already have a wealth of data that will tell any man with Gleason 9 cancer that if he's not treated, he is likely to progress and die of his disease. So as we look at this, we always try to help you make good decisions, and these are it's good financial decisions, because as you're looking at this is curing your cancer, right? If you undergo a robotic prostatectomy, the chances of you dying of prostate cancer in the next 15 years drops to less than 1%. The doctor gets paid about $1,200 to do this. And so compare that to someone wanting $4,000 for a genetics test that may or may not even help you make a decision. So it's just certain, the value or things. My biopsy is positive for prostate cancer. What are my options? Okay. The first thing, active surveillance. What does that mean? I usually tell patients there's not a one-time sale on prostate cancer treatment. Trust me, my office will be open 4 months from now. Sarasota Memorial will be open 4 months from now. Everybody's going to be open 4 months from now. Active surveillance for prostate cancer simply means that we believe that it is safe, that rather than undergoing direct treatment, that you can undergo surveillance of this for 4 months and then reassess. Okay, it's a 4-month contract. And then at that point, a digital rectal exam, a PSA, we will continue to give you surveillance of that. At some point, right, you may need a repeat biopsy. And that is known in the urologic literature as the first surveillance biopsy. First surveillance biopsy is the most important thing in an active surveillance person's lifespan. I have lots of I have a small practice. I'm one person. And yes, I'm a very busy doctor. I see lots of patients that I hate to tell patients, no, I can't see you. But I have over 400 men that I follow for active surveillance for prostate cancer. Okay, these are men that have all been offered treatment somewhere, have gone through, and every year I'll have men coming onto active surveillance, and some men are going off of active surveillance. Some because they die of other causes, okay? Some because they've progressed and they're no longer good candidates for active surveillance. But, if I can cure you at age 72 as well as I could cure you at age 68, why not cure you at age 72? No matter how good of a surgeon or a radiation oncologist or any type of physician I am, and I say I have the lowest risk, I can't compete with zero risk, right? If you're on active surveillance, you're taking, relatively speaking, zero risk. I can't compete with that. So active surveillance should be the first topic of conversation. Am I a candidate for it? Okay, and that's the first thing I do. The second thing is we have any of the treatment options for radiation therapy, any of the treatment options for ablation, freezing or heating, any of the options for hormone therapy, and then we have robotic prostatectomy, which you're watching. And at this point now, we are taking down, we've already separated the bladder neck, we've already separated the lateral bladder fibers, and here you'll see me dissecting. This is there's the lateral bladder neck, and notice that when we get laterally like this, we like to put these clips on, but down here are going to be the seminal vesicles and the vas deferens. And so just step by step, I always tell patients as we're going through this that remember Minnesota Fats when he was going into a pool hall. He would walk into the pool hall and he would do, put 15 balls in 6 different pockets, step by step by step. One shot sets up the next one. So you limit. I do it the same way for 3,000 cases. The same way, my assistants know exactly what I'm going to do next, and we go through and you limit the morbidity. Now, what is radiation therapy? Radiation therapy is FDA approved. It's been around forever. And people get so confused. Well, I didn't have radiation. I had the seeds. I didn't have radiation. I had the rods. Oh, I had proton beam therapy. I didn't have radiation. All of the ways that we deliver radiation come to the point of having 8,000 rads of ionizing radiation put in your pelvis. Whether we are placing radioactive seeds into your prostate and then supplementing that with external beam radiation, whether we are putting high-dose radiation rods in, or whether we are using photons from a linear accelerator, that we call that IMRT, or whether we are putting in alpha particles from a proton beam accelerator. It's all a matter of putting 8,000 rads of ionizing radiation into your pelvis, and each type has a little bit of difference in it. For example, it's always been the product of the desire to cure cancer to give more and more and more radiation. But why do we limit it to 8,000 rads? And it's usually about 7,800 rads. Because if you put more ionizing radiation into a man's pelvis than that, even though it might have a better cancer cure or cancer cell kill rate, side effects and the risk to the patient becomes just unbearably high. Secondary malignancies such as bladder cancer, rectal cancer, the rates go from just being higher to being way too high for having radiation cystitis or proctitis or complications from it. So there's only so much radiation we can give. But that's an FDA-approved treatment, and so don't get confused so much about how we deliver it. One of the downsides of having the brachytherapy things are that you have to get anesthesia, and often that anesthesia to put in the radioactive seeds is longer than removing your prostate. And so, we have to look, and then if you have high-dose rods, that's 2 sets of anesthesia. The next thing we look at is ablations. Cryoablation has been around for many, many years. It's FDA approved. And what's interesting is you often hear people talk about focal therapy. Well, we've been doing focal therapy with cryoablation for years, but why don't you ever see people offering focal therapy with cryoablation now? Well, it's FDA approved and it's covered by Medicare, and I think the doctor gets paid $400 to do it. So you're never going to see an advertisement for it, right? And the second thing is, just about everyone, don't get me wrong, I would never turn down $400. If it fell on the floor, I'd reach over and pick it up. But for most people, who would be a candidate for focal therapy, what else they're a good candidate for, right? Just active surveillance, 0 risk. You don't have to go to the operating room. You don't have to get anesthesia. You don't have to have a cryoablation probe placed in. And of course, you can do full gland ablation with cryoablation, but you can't stop freezing or heating on a dime. As you watch this, at some point you're going to see me take away and separate nerve bundles, and you can do that with sub-millimeter tips of instruments. But with freezing, you know, you can't have something minus 40 degrees and then 1 or 2 millimeters over. Now it's just room, you know, it's like body temperature. And so it has a lot of the sort of long-term side effects from that. There's also something that you hear regularly now. It's called high-intensity focused ultrasound, HIFU. HIFU has been around for about 30 or 40 years. For a number of years, I had the privilege of being a professor at the University of Lausanne in Switzerland. And honestly, if I had not met my wife, she's a Scandinavian who thinks she's Floridian because she was born here, I probably would still be in Switzerland because, you know, I had no reason to ever leave. But, you know, while I was there, Europeans were much more interested in sort of taking experimental approaches than Americans are, you know, and so I had a number of my colleagues who were very good scientists. They did HIFU, or high-intensity focused ultrasound, and what we learned through the years was that for people who were excellent candidates for active surveillance, meaning not to do any treatment, they tended to do well with HIFU, right? Anybody would do well with anything. But for people who had significant disease, they were almost never cured. And the problem with them is that they ended up becoming salvage therapy. And to this day, I probably will see 2 to 3 patients a week that I have to perform salvage therapy for because they were given an incomplete treatment to begin with. And so there are certain things about the, you know, the use of HIFU. It's Medicare approved to use it. I mean, it's not Medicare approved, it's FDA approved to do it in the United States. But red flag number one is that Medicare and insurance don't pay for it because they already know that it doesn't work very well. And so what the first thing they're going to have to do after it doesn't work well, then they're going to have to pay for salvage therapy. And what's the cheapest way to do anything in medicine? The cheapest way to do anything in medicine is to do it right the first time, right? It doesn't matter how expensive the first treatment is. If it cures it, that's good. The problem you have is when you have things that get treated and then you're treated for the rest of your life. Let's see, we've already got, if you look at this, this is the vasa in the middle and the seminal vesicles, and we're just going down and just separating all of that. And the rectum is beneath this, and the neurovascular bundles are lateral, and then the space of Denonviller is open, and you see I'm grabbing the seminal vesicle on the left side. The blood supply always comes in from the lateral to the medial, from the outside to the inside. And you can see it's just lifting that up, and then we're going to be able to separate the tissue to get underneath. Right through the abdomen, right here. Just you go, when you do a robotic prostatectomy, you go right at the belly button for the camera, and you have 2 robotic arms to the left and 2 robotic arms to the right. That's the neat thing about the Da Vinci robot compared to all the previous robots. Being an MIT PhD throughout the 90s and the early 2000s, every robot that was created for surgical use was paraded to me, and I was always enjoyed looking at them. Most of them were cute devices, but they did not make us better surgeons. I control all of the arms for this one. I have 2 left hands, and I have a clutch, and then you're using your eyes, both hands, and both feet. You know, this is, but I can't play music, but I can do this. And you also have an assistant port where the assistant can place things in. Now, when you look at hormone therapy, has anyone here had androgen deprivation therapy or hormone therapy? Raise your hand. Did you guys really understand what you were getting when it was given to you? Did anyone use the term chemical castration? Because essentially when you're getting hormone therapy, as I tell people, hormone therapy is a wonderful treatment for prostate cancer. In fact, 2 Nobel Prizes have been given for hormone therapy. Professor Huggins for his work in 1941 when he was given the Nobel Prize because he was the first one to determine that men who were progressing and dying of prostate cancer, if he castrated them, they went into remission and lived much longer. They did well. The second one was Professor Andrew Shalley, who, believe it or not, is still alive in his mid to late 90s in Miami. He was in New Orleans but got relocated after Katrina. Intellectually active, but he developed the chemical castration drugs, which are decapeptides. And and so that instead of removing a man's testicles, we can give reversible injections. Now, it is acceptable and FDA approved to deliver castration for prostate cancer. And I do have a number of men, you might know them in my practice, they come to see me, and they're not crazy when they say, oh yeah, Dr. Carey just comes in, he just gives me a shot, that's all he says I need. Well, that's great, he's not lying, but it also means that cancer is probably not curable, right? Because it's given, you're having to give them chemical castration agents because their cancer is already spread. And so the thing that people should know before they embark, part of what I do for treating prostate cancer is, to the best of my ability, make sure that they never have to go on hormone therapy. Because when I take away your testosterone, that's what these shots do. It's a peptide. It goes into your subcutaneous fat. It goes to your brain. It keeps your brain from communicating to your testicles, and your testicles stop producing testosterone. And so you go from having a normal testosterone to castrate levels of testosterone. That's what the hormone therapy does. Now, you will get hot flashes. You'll get decreased energy. You will have immediate loss of libido, right? You don't have the loss of intellectual libido. You have the loss of innate libido. Like, for example, when you see your spouse and you'll remember, you'll want to have intimacy, but what happens is you lose that drive. And we see the similar thing in women with breast cancer who are estrogen positive. And part of the algorithm for treating breast cancer is that these women are given anti-estrogen pills. They remove their ovaries, and give them anti-estrogens. The women get vaginal atrophy, vaginal dryness, and they end up getting loss of libido. They don't love their husband any less. They just have no desire. It's no hormone. So life is always better with a normal hormonal axis. Now, having said that, for people with metastatic prostate cancer, the chemical castration drugs will give you long years of life, and it's a great treatment. But if it can be avoided for men who could be cured locally, avoid it at all costs, because men are going to suffer with the hormone therapy. In addition to the fatigue, the loss of libido, the loss of desire, the loss of energy, there are the real issues of loss of muscle mass, loss of bone mineral density, loss of your ability to protect from heart attacks and strokes. And in fact, for the old drugs, you gotta love this, for the old drugs that Dr. Shalley got a Nobel Prize for, there's an FDA warning for dementia and heart disease and strokes. And part of the FDA's purpose is like to help doctors know that these drugs should not be used indiscriminately, that there is a cost and a consequence for using them. Now, if the choice is between death by metastatic prostate cancer and the risk of a heart attack or stroke, prevent the real thing and go and get it treated. But if you can avoid it, do so. You're watching the robotic prostatectomy, and in part right now, you are actually seeing the mythical part of neurovascular bundle sparing. And if you look, I think I got buzzed. But this is the neurovascular bundle to the left. This is the prostate, and that's the neurovascular bundle. And just watch how I separate it meticulously. This is real time in the operating room, and so we're separating it. You can't do this with freezing or heating. Land that time forgot. And now you can look. There is the prostate to the right. That's the left neurovascular bundle, and there's the prostate. And now I'm going to come back and you're going to see me separate, because right here is where the prostatic pedicles are. Okay? I'm going to go there. We're just going to put clips across it. You're going to have to present it in a way where we can do that. Why do men, when they're offered it, most often choose to have a robotic prostatectomy? In general, it comes down to one thing: cancer-specific survival. In America, you might ask, why don't we have randomized control trials? You know, we've got a government, we've got the NIH. Why haven't there been trials where we randomize men to radiation therapy and randomize them or to surgery? Because American men like to make their own decisions. No one's going to walk in, think about their prostate cancer, and then reach into a bag and pick out their treatment. Okay? They can do things like that in Sweden sometimes. You know, the answer is, yeah, I got this. And I love my European colleagues. They're much more amenable to this. But in America, that's not going to happen. However, hundreds of thousands of people get treated for prostate cancer every year. And in general, we follow them and we know the outcomes. And so we have something called propensity-based match pair analyses. I do that here at Sarasota Memorial to analyze a lot of our outcomes. And what we've found is that there have been 15 major studies where we've looked retrospectively where men have been matched in pairs for the grade, stage, age, medical comorbidities to the nth degree. And we find that whether it's the lowest risk or the highest risk, those people who have surgery first have the best cancer-specific survival, and it's not even close, okay? Now, and the other part is the higher the risk, the greater the benefit, okay? Because people with lower risk tend to do well regardless. And so we look at that. It's just 15 propensity-based match pair analyses studies. And the person who's the sort of the major author for many of them is a guy named Lauren Klotz. He's a Canadian. And of course, he's had a chance in Canada to do lots of these studies. The other thing is, we like to get 100% cell kill. When you have surgery, you get a 100% cell kill. The prostate comes out. You don't have to ask, did you freeze it all, heat it all, radiate it all? It just all comes out. The second or the third thing is, when you take out the prostate, as you're seeing done here, the chances of you getting to know the entire story are very high, because you now can take the prostate and study that as separate. So you have post-operative staging and grading that tells you if you've got something much worse than you thought you did. The fourth thing is, and I learned so much about this from my own dad who had prostate cancer, is that he just said, I don't want to be that guy that spends his time in a medical oncologist's office or a urologist's office getting treated for prostate cancer for the rest of his life. And so if your PSA goes to an undetectable level after a radical prostatectomy and simply stays at an undetectable level, you don't need CAT scans, PET scans, bone scans, MRIs. You just see the doctor for occasionally, you get your PSA, and that's it. You're not in the office all the time. And so those are just some of the myths that we look at. So number 7, the number of men that will come to me and they'll say, you know, it doesn't really matter what treatment you have for prostate cancer. I was told they all have the same outcome. And that's false. I mean, no, it doesn't. Each one has its own set of risks and benefits, okay? But in general, what you want to do is to have a good sense of what's important to you. The younger you are, the more cancer-specific survival means to you, right? The older you are, it's still important, but it's really a matter of, like, how can you keep me on, I'll often have an 80-year-old man come to me and he'll say, like, Dr. Carey, I don't ever want to have hormone therapy. I don't want to be castrated. Well, that man's 80 years old. He's in good health. You know what he needs? He needs a robotic prostatectomy. Okay, about $8,000 or $9,000 changes hand from Medicare to the hospital and the doctor, and the guy's done. He's probably doesn't need prostate cancer treatment 15 years. He has a less than 1% chance of dying of prostate cancer in the next 15 years. And you take it in comparison with radiation therapy, he's going to have a combination of chemical castration and radiation because of the synergy effect that's necessary to make that work for high-grade, high-risk disease. So those are the types of things where you have to look at it. Every treatment is quite unique. And when patients come to me for a discussion, and I think some of you have been in that room, it's about an hour-long discussion about what to do, about what your risks and benefits are. There is no free lunch in prostate cancer. The other myth is you get diagnosed and you find out a week later exactly what you have. I need to be treated right away. Most of you, whatever prostate cancer you have, you've been working on it for 50 years, 60 years, 70 years, however long it's been. You don't need to be treated right away. We have studied this time and again. Regardless of who you are, the time to treatment is irrelevant, okay, within a 3 to 4 to 5 month waiting period. What matters is what decision you make for your treatment, because certain treatment options have better cancer-specific survivals than others. If you have a prostatectomy, what matters is what is the final pathology. Like if you have a final pathology that's different from your biopsy, that's more aggressive or less aggressive, that prognosis is the best. The third thing is going to be how well your treatment is done. Like if your surgery, is it going to be done like this? Okay, and by the way, this looks like the lymph node dissection. So as you have when you have a prostatectomy, one of the advantages, you're also going to have the lymph nodes removed that are most likely to carry metastatic prostate cancer. So those three things matter, but the time to treatment doesn't. Number 10, my PSA is rising after a radical prostatectomy. What do I do? Most of the time, the answer is don't do anything. Now, as doctors, we're well armed to treat you with any of a number of things, right? But, what is the risk? We know that having a radical prostatectomy, your chances of dying of prostate cancer in the next 15 years is less than 1%. Okay, now some people have higher risk than others, but let's say your PSA is rising and doubling every 2 years. Well, let's calculate that out until you're 112, right? And let's plan to treat you when you're, when you're 112. Come back and see me. The other thing is, what if your PSA is doubling every 3 months? Well, we already know that that's not good. That's almost certain a harbinger that you have metastatic prostate cancer, whether you have a positive scan or don't have a positive scan. And those people need to be on hormone therapy because the PSA doubling rate. So it's not just a matter of what the PSA is. There's a thought process. And what that thought process always has to be is, what is your risk to suffer and die if we don't act? Because everything we do as physicians, giving you medicine, giving you radiation, giving you surgery, giving you any of these other things, there's a risk-benefit analysis. And make sure that the benefit is in your favor more so than the risk. What does it mean to be on androgen deprivation therapy? And are all chemical castration agents the same? FDA warnings. I've touched on this a little bit. Now, while Professor Schally was getting a Nobel Prize, I was a young assistant professor in Switzerland. I was busy with a number of pursuits, but one of them I had my own lab, and I had gotten my PhD in designing robotic peptide synthesizers, and so I was rapidly producing analogs that would be better chemical castration agents. And in Switzerland, you're always working with their industry, which was Ciba, Roche, and Sandoz, and we made a lot of wonderful drugs, none of which made it to the market, which is not unusual, and which is why I'm still working today. But yeah, but the idea was, there was a company in Switzerland called Ferring, and they have produced a unique chemical castration agent that I almost always use exclusively. Because unlike the the drugs, you've probably heard of them. They're generics now, Lupron, Eligard, um, Zoladex, etc. Those are gonadotropin-releasing hormone agonists. They stimulate the brain until the brain burns out the pituitary receptors and you no longer produce testosterone. The Garelex, or Firmagon, is a unique. It is an antagonist. And what it does is it blocks. It is a blocker. It doesn't stimulate the cells. And so in addition to having the advantage that when you're injected, it doesn't take a month to work, it doesn't cause a transient rise in testosterone, that's some of the old drugs, you're immediately castrated. But most importantly, what do these chemical castration drugs have an FDA warning for? Heart attacks, strokes, dementia, vascular disease. We believe it's not because of the decrease in testosterone, but because these things activate the T cells that cause inflammation in your vasculature that end up causing you to get heart attacks and strokes and dementia. And so almost exclusively, I will use the one that doesn't have the FDA warning. Is it a nuisance? Yeah. Is it financially good for the doctor? No, because you can't really get competitive. You can't go out and be a businessman and say, all right, who's going to give me the best rate for my office? You're only using one drug. They just come by and they tell you what the price is, right? And of course, the way this works in a doctor's office, the Medicare fixes what the doctor can be reimbursed at, and the company fixes the price at what the drug is sold at. And you hope that there's at least a couple of pennies difference, but it's not like I can set the price for either one. But I exclusively use that one. And so if you have to get chemical castration, you should get the drug that doesn't have the FDA warning. And, enough pressure isn't put out by patients. If you go to any of these treatment mills, what are you going to get? You're going to get the cheapest drug that they can get, or the thing that's the most profitable. And it's not the doctor's fault so much, and it's not, but, they're run by certain, by financial things, and they just say this is what we're going to give. Yeah. A good question. And I've been around for a long time, and I've had to learn that sometimes I'm around all of my colleagues that I got my PhD with at MIT and Harvard, and they're really good at understanding the technical aspects of what I do, but they don't have any clinical sense. And a lot of my colleagues who are physicians have such clinical sense, but they don't have any concept of what the technical things are. And yes, I mean, I think we're guilty as a profession of medicine that I bet a lot of people were never even given a talk. When you were given chemical castration, did any of you get a discussion on what options were available to you, or were you just given a shot? You're just given a shot. And so I think the audience has answered that people don't really do a good job of explaining that. I have number what was it? Number 12. We always see things. Well, you ask, I mean, number one, well, he wants to know, how can a patient know this? And of course, it's easy for me to tell this group what the distinction is, but that doesn't really help the problem, because most men are not going to be sophisticated enough as they walk in to ask that question. And so that's the job and the responsibility of the physician to do that. But in this case, there's one drug that's a gonadotropin-releasing hormone antagonist. And a simple question to your physician, is there an alternative? I see that there is an FDA warning to the drug you're about to give me. Is there an equivalent agent that doesn't have an FDA warning against it? Okay? And that would be a question that would do it. But what you'll find interesting is there are many places here that are driven by big corporate America, because doctors don't run their practices anymore. They can't get the one that doesn't have the FDA warning. That is, I mean, you don't lose any. This is one of the most important decisions in your life, right? You know, if a doctor can't look you in the eye and make you comfortable and answer your questions, yeah, go down the street. As I routinely tell people who come to me and they have issues about, you know, every time I drink a cup of coffee, I urinate too frequently. Every time I have a glass of wine, I urinate too frequently. And I'll say, well, if I take away cups of coffee and glasses of wine, I'm not going to be a very popular doctor. You're going to walk down the street and find a smart one. And so, you know, we have to be, you know, sort of logical, but at some point that patient has to understand their behavioral changes. What about highly advertised things? You know, you say, yes, but I saw this cancer center. It's on TV all the time. You know, that they offered me hope. They offered me, you know, if they have, trust me, for someone who lives in a 2,000 square foot house where I work all day and all night as a cancer surgeon, you know, if they've got money to advertise, something's wrong. You know, that's kind of a red flag. You're probably going to get offered the most profitable treatment, and it may not be the best treatment. It may be a variation of the best treatment. But, you know, at some point, do you really need to have the most profitable thing done, or do you need what's done for you? The other thing is, my doctor has offered me a new procedure, and it's really, really a new procedure, and nobody else knows about it. You know, the only complaint is, the only problem is, it's, you know, it is only covered if you pay me cash. And so let me get this right. You have someone who's got a PhD from MIT. I've spent my entire life treating cancer, and I don't know about a treatment that you're going to pay $35,000 cash for. You trust me, if it were the right thing to do for you, I would take the $35,000 cash and do the right thing. The problem is, usually there's a catch to that, right? There are a lot of red flags. No one else in town is doing it. They're advertising on the Sunday morning papers to do it, and it's not covered by Medicare or insurance. Why would Medicare and insurance not cover something that works? You know, and in general, you always have to be careful about things that are going to have a perpetual line of expensive imaging, a perpetual line of expensive secondary treatments. Ideally, get cured, go on with your life, okay? And so, anyone familiar with a company called ProPublica? ProPublica is a really neat place. They're like a badger. They're like this watchdog for the American consumer. And normally they scare the dickens out of people, but I've found them to be fairly interesting. And for example, they put out a surgeon scorecard. And what I've found through the years, and by the way, these are the neurovascular bundles. You can see them very clearly, right there and right there. So this is a person who's had his prostate removed, and all of their neurovascular bundles are intact. You can see them crystal clear. There's the bladder neck, and there's the urethra. And notice that I'm not just going to whip stitch this to that, okay? I'm going to put together, I'm going to repair the fascia of Denonvilliers. Denonvilliers was a French anatomist, and I'm going to take this fascia and bring it up to here so that you repair the person's pelvic floor, and so there's not going to be any type of tension on the anastomosis. And just like when I do prolapse repair in women who have had childbirth, and when they cough, laugh, sneeze, they leak urine, well, I'm going to repair the pelvic floor of the man who has prostate cancer. You know, this only makes sense. So it goes from there. Now, where were we? The ProPublica Surgeon Scorecard is a neat thing. They don't listen to what the hospital has to say, because the hospital has an agenda. They don't listen to what the surgeon has to say, or any device manufacturer. What they do is they take the Medicare number or the insurance number of the patient who's being treated, and they take the Medicare or insurance identifier number of the physician who did the treatment, and for this came prostate removal, and they will follow these patients for years, and they will see who had to be readmitted to the hospital, who needed a blood transfusion, who had to get retreated for cancer, who had a complication, heart attack, stroke, etc. And I was very pleased when they came out with this damning information that I was the safest surgeon in the state of Florida for prostate removal, and it wasn't even close. You know, I mean, if you look at, and this is the safest hospital in the state of Florida for prostate removal. And I can't begin to tell you how hard it is. Okay? I've resisted for years running a prostate mill where I would have someone open and close for me, bringing in foreign doctors and having them do part of my surgery for me. As you're watching here, this looks like it's a fluid motion because it is a fluid motion. There's a surgeon doing the entire procedure who's well skilled at it and an assistant who's well skilled at it. So in the ProPublica Surgeon Scorecard, you can go to any hospital in Florida, and up at the top left-hand corner, you'll see the most, the least complications and the safest surgery all the way down. And basically, the data is very transparent. Who has the complications, who doesn't, who gets readmitted, who doesn't. And the other thing is that ProPublica does is they follow gifts to physicians. And it disheartens me greatly to know how little gifts I've been given by the pharmaceutical industry. But it's interesting, if you go there, you'll find that I had 14 gifts given to me. And, as it turns out, every time they come by my office to drop off Viagra samples that I give to my patients, that's a gift to the to the doctor. What's that? Because pharmaceutical representatives, whenever they visit a doctor's office, now, if they visit your local politician's office, they can drop off whatever bag of money they want. That doesn't get reported. But if they go to the physician's office, they have to report it to the federal authorities. And so every Viagra sample, Cialis sample, or if they gave my nurse a sandwich or something like that, that gets reported. So it's not a big deal to see a couple of $1,000, go to a physician, because that's what it is. Because I was wondering, hey, where's where's my watch or something? Where's $1,000? But there are other people, like for these cash pay things. Look back, there will be a $170,000 gift, not treatment for procedure, but gifts from the pharmaceutical industry that gets reported on ProPublica. And so again, that's another red flag. If your doctor is offering you a procedure that nobody else offers you, right, that is cash pay, and the company who stands to benefit from that just gave them $170,000 reported on that, that's one of the myths that you have to say, this is not, the way that we want to do it. And sometimes doctors get really angry, like, why are we scrutinized, and yet everywhere else in society it isn't? It's fine. It really is. It doesn't, it doesn't matter. I mean, I get along fine with all my pharmaceutical colleagues. Give me a good drug, and I'll give it to the patient. And we'll talk about that in just a second. Yeah. ProPublica Surgeon Scorecard, and then you'll go there and they'll have like 10 index cases, and you can say prostate removal and state. You can look up the individual surgeon you're thinking about using, or you look up the hospital, or you can just look up the state. They made it quite convenient. The big deal now for men with prostate cancer, metastatic castrate-resistant prostate cancer. What does that mean? Well, in general in America, and by the way, you just saw us, you see how that gets focused? We've just switched over to the 0-degree lens, and this is the opening of the bladder neck right here, and that's the urethra. And there's the Foley catheter showing the urethra. And so now, just calmly, without any fanfare, we're going to sew up the bladder neck to the urethra. You're going to see this opening right here go in and form a mucosa to mucosa tubular anastomosis. Feet are that way, head is that way, and this is the pelvic floor. The penis is going out there, the bladder is here, and the intestines are up here. And there's no retractors in, it's all just positioning, and it's all a matter of, when something, something looks easy, it's because someone set it up to look easy. So there's job security. The thing is, how do people die of prostate cancer? Why is it that in today's world, 32,000 men each year die of prostate cancer? And given the demographics of Sarasota, it's a lot of those are here, right in Southwest Florida. It's because not only has their prostate cancer spread and taken over and physiologically, it's obviously going to be castrate-resistant disease. It's growing in the absence of testosterone. And historically, when men would develop this state of disease, they had, 12 to 24 months to live, and that was it. And it's a miserable way to die, which is one of the things that gets lost in the PSA controversy and all the other controversies, and why it's so important to have, cancer cure for this. So when you have metastatic castrate-resistant prostate cancer now, what's very nice is that people can successfully be treated. There are multiple new drugs that when you take them, they're not IV, you just take them orally, and often you can get anywhere from 24 to 36 months extra years of survival. We have wonderful men living in Sarasota, and many of them are my patients, who are on these drugs. And they will tell you, yes, I feel fatigued. Yes, I'm more tired than I used to be. Boy, you took away my energy. And I'll just listen to that every month because they're not dead and they're not suffering. Now, these two drugs, abiraterone acetate and enzalutamide, have been studied very carefully, and they work by taking away the mechanisms that these cancer cells use in processing and using testosterone, even tiny amounts of it. And you contrast that. There are certain things for prostate immunotherapy where you have drugs that will cost $100,000 for a one-shot thing. And just, excuse me, but I've never seen anyone benefit from it. And it just doesn't make sense to me to give drugs that are extraordinarily expensive that don't, that men just don't seem to benefit. There are some drugs that when I was a 25-year-old man, I was working on similar things where you inject it, it gets into your bones, and it delivers radiation. It's going to kill all the cancer cells. Well, when I was 25, I didn't necessarily ask, well, what could possibly go wrong with this, right? And as a physician, as you get later, you realize that, sometimes you have very aggressive practitioners around you who deliver this drug, and, patients sometimes don't do well. And so they need to be counseled before you get some systemic chemotherapy treatment. What could possibly go wrong? Am I going to, like I've seen people never make another red blood cell, need blood transfusions, people who might have 3, 4, 5 years to live, end up dying within 6 months. And so in general, when you're thinking about metastatic castrate-resistant prostate cancer, this is a very important deal, and there are safe, reliable drug regimens that you can use that will get you many extra years of life. The usual thing, can I get home to Massachusetts for this summer on the Cape, and can I come back to Sarasota? And if you can give them you can give a man 3 more seasons of that, maybe see some grandchild graduate from high school, take the safe route, okay? I'm not saying that you can't take risks with prostate cancer, but sometimes the best risk is, 0 risk for that. You guys have been very patient. You've had a great audience. You've essentially watched a robotic prostatectomy done. This case is complete. In the time that it's taken for us to have this decision, someone's cancer was cured. Their PSA is going to be undetectable, and the chances of them ever dying of prostate cancer is going to be less than 1%. I sort of put together a group of questions for everyone to give some thought to with regards to, that I hear every day. And now it's your turn. If you have any questions, please feel free to ask. Yes. So let's start with the PCA3 test. The PCA3 test is a wonderful test. It was put out initially by Johns Hopkins with a lot of hype. And remember, what is it competing with? It's competing with a proven veteran, the PSA test. The PSA test may have a few warts on it, right? but it's very reliable when it's used intelligently, just the way we talked about in the first of this. And the PCA3 test is something that gives an added level of security, but yet was only marginally better at certain things in the PSA. And what we found was that it really didn't find a role that was covered by patients willing to pay for it, doctors willing to prescribe it. For a while, the Medicare would pay for it for the following condition, where people had a rising PSA, had a negative biopsy, and then their PSA continued to rise, and then you could get a PCA3 test. And I gradually stopped using it because, you know, as I tell people all the times, you know, don't be reluctant to accept the congratulations I'm giving you. Some men are going to have an elevated PSA with PSA progression, an abnormal PSA-free PSA ratio, a firm prostate, and an abnormal PCA3 test, and yes, you don't have cancer. By definition, some of you have to not have cancer or we wouldn't need to do a biopsy, right? So there are going to be some men who just have inflammatory changes, and that goes with that. The 4K test is, again, one of these things. They don't, you know, that's using the kallikrein test. It's great. They're wonderful. I'm glad that someone is measuring kallikreins. You know, you want to be interested in me? Show me the direct result of it. But no, they'll measure your kallikreins, and then they'll put in a proprietary algorithm with all the other data, and then they'll tell you what your risk of prostate cancer is. And the 4K test has been around forever. And for doctors who practice differently from me, it might be useful, okay? Meaning that if all you do is look at the total PSA and then you want to run some expensive test, yeah, that works, I suppose. It makes you slightly better. But for me, I'm going to see, someone will come to me with an elevated PSA. We don't just rush to treatment. You know, we'll see if we'll follow their PSA. And if someone has had multiple rises in their PSA over time, they have an abnormal digital rectal exam, or things that make me highly suspicious that they have prostate cancer, then I do a biopsy. And the 4K test really adds nothing to that. It might go from 88% sure to 88.1% sure for several $1,000s, and it just doesn't make sense. And the other one was confirmed DX. And yes, you can do things on a negative biopsy. However, my job when I biopsy someone is to do a thorough job of that biopsy, so that if you have a negative biopsy from me, I can look you in the eye and say that the chances of us missing a significant cancer is exceeding. And so adding, like, you know, and so what part of a confirmed DX or anything is going to make me say, okay, here's this guy, I just biopsied him very thoroughly, and now we have the result of this test. What is it going to make me re-biopsy him, or is it going to make me treat him, or make me? And the answer is they just don't have something that's powerful enough. You know, so we just need more robust genetic tests. These things get FDA approval usually through the passage of, you know, the way things are done in government. You know, you sleep with the FDA, they do whatever they have to do with the FDA, and they get it approved. And that's great. I mean, it means, remember, the FDA isn't telling you what's a good test or not. The FDA is telling you, you know, what is safe, that you're not going to hurt yourself by getting a confirmed MDX. My job is to tell you, you know, is this going to benefit you? Is it going to help you make a decision? Because you're better off going out and buying a new bedroom suit, you know, or you're buying or buying something else until something can change your mind. Yes. every year we have something we call a Jewett nodule. And I'll probably have 3 or 4 men each year whose, quote, lives were saved because their primary care physician, even with a PSA that was very low, they felt what we call a Jewett nodule. You know, you can't get anything named after you now because, you know, but they'll feel a hard nodule and they'll send them to me, and it's like, yeah, this is, you either fell off a bike as a kid or you've got cancer. And so when you do this, these people with low PSAs and a hard nodule, those are the ones at greatest risk to die because they clearly have a significant cancer, but it's not producing much PSA. And so, yes, and those are the ones you look at. Yep. I'll get you next, Israel. You go ahead, yes. I think that for low-risk cancer, you should just go on active surveillance. I think for low-risk cancer, you should go on active surveillance. Number 2, I think you should believe not individual, you know, studies of limited nature, but believe the propensity-based match pair analyses, which have carefully looked at this over and over again. We know that for low-risk cancer, right, anything we do is going to look pretty good for a decade or so because we've already told you that active surveillance is a good idea. And so, you know, you have to look at what are the downsides down the road, et cetera. But yes, you know, I think for low-risk disease, my advice would be go on active surveillance. Of course. Heat and the prostate typically don't mix because while we can heat something, you know, in various parts of the body, usually those are places you don't have sex through and you don't urinate through 5 or 6 or 7 or 8 or 20 times a day. And so we've done lots of historical treatments of the prostate where we use radiofrequency ablation to deliver heat, where we've used focused ultrasound to deliver heat. You're more likely to form abscesses and have problems. There was a tuna procedure which for a while, and we just stopped. When I say we, I never did them. It just didn't make a whole lot of sense. You know, whatever the answer to the question is, sticking a hot needle into a prostate didn't seem like a good idea. But people would get abscesses and problems that would lead to focus things that were really problematic, and that would then lead to more treatment. And once you've gotten an abscess in the prostate, it's really hard. Okay. It is. That's called a salvage prostatectomy. And there are like 2 of us in Florida that do them. And they're always harder. And it's not so much, I mean, you'll have a prostatectomy where the same principal steps are done, but all the tissue is fused and sort of, you know, together, and a lot of parts of it are dead from the radiation. So the risks are higher, but sometimes, you know, people just had cancer. This wasn't sensitive to radiation, and it's aggressive, high-grade disease, and it's still there. And I'll do you know, multiple ones of those a month. You know, we see it. And I'll be glad to stay for ones who have them later. Go ahead, sir. Well, the 2 things, was that with chemical castration? Did you have a hormone shot with it? Okay, so that's the effect of the hormones. And so, you know, when you give someone chemical castration, the PSA should go to an undetectable level. And so the downside with radiation is you really never know, is it the hormone therapy that's causing the PSA to go down? And so typically they'll give you a limited, we deliver a limited amount of hormone therapy, maybe for 6 months. I mean, historically we would say 2 years. Right. And so you've had chemical castration, and that's what's driving the PSA. Now, the chemical castration was delivered over 3 months, but it's usually about a year to a year and a half before your testosterone comes back to normal, and then you'll see what your true nadir is. And then, you know, you want the nadir to go, you know, to stay low, but, you know, a good number of people, the PSA will just keep rising. And if it does, you either have metastatic disease, or which was maybe didn't show up, it's called micrometastatic disease, or you still have residual cancer. Provenge is one of the things. I made a number of agents just like Provenge when I was a professor in Switzerland. And typically what we're trying to do is to use the immune system, your own immune system, to fight the cancer. And it sounds great, right? But, you know, the immune system is a very difficult thing to understand, all right? And the problem that I have with the Provenge protocol is that it typically doesn't, you don't see a drop in PSA reliably, and I'm not really comfortable with the FDA approval process where they showed efficacy, where supposedly there was some survival advantage in a certain subgroup of patients. But compared, and that's like $96,000 or whatever we spend on that, you could have, you know, abiraterone acetate or enzalutamide, two known good metastatic castrate-resistant prostate cancer drugs, and just have that for years and years and years, and you know that that's going to be reliable.
This has been an incredible presentation, Russ, so we want to thank Dr. Carey. Hear her.